Hello, hello, and good morning. Thank you for those kind words. Let me share my screen here. Doo-doo-doo-doo. And we're doing slideshow. Okay. Can you hear me well?
Yeah.
Yes. Love it. Okay, so good morning, everyone. All of you beautiful souls. Thank you for being here and joining today. This is a topic that I really enjoy, and it just it's kind of like innate in me. So I hope you enjoy it as well. And if you can learn a couple of things, that's also great. I'm Karina Viloria-Rodriguez. Yes, I'm by the end of my fellowship now in academic integrative health. So it's a 2-year one at UW. And today's topic is going to be integrative medicine in hospital care. I want to start by just reviewing our objectives, like doing like definition of integrative medicine and its role in enhancing conventional inpatient care, recognizing and applying evidence-based integrative therapies in the hospital setting. We're gonna discuss a couple of opportunities to collaborate with multidisciplinary teams to create holistic treatment plans. And lastly, applying mindfulness and stress reduction and some self-care techniques to enhance provider well-being and resilience as well. I begin by acknowledging that the land on which I live and work is the ancestral homeland of indigenous people who have stewarded these territories since time immemorial. Their connection to the land remains strong despite histories of displacement, violence, and systemic injustice. I honor their resilience, resistance, and continued presence. As a Puerto Rican of Dominican descent, I also carry the weight of colonial histories that continue to shape my own communities. Puerto Rico remains under a colonial relationship with the United States, and its people continue to navigate the complexities of limited political representation and autonomy. The Dominican Republic, too, bears a history of resistance to foreign interventions and ongoing struggles for self-determination. In recognizing these intertwined legacies of colonization and survival, I commit to practicing awareness, solidarity, and justice in the spaces I inhabit and the work I do. And now these are my disclosures. I have none except all my biases. You're going to see them throughout the presentation. So just bear with me. Let's start with, integrative medicine. We've all seen this definition of integrative medicine on health. It reaffirms the importance of the relationship between practitioner and patient, focuses on the whole person, is informed by evidence, and makes use of all appropriate therapeutic and lifestyle approaches, healthcare professionals, and disciplines to achieve optimal health and healing. In this definition by the Academic Consortium of Integrative Medicine, I'm not seeing anything that it is specific to one location or the other. So we just have to keep that in mind. It's just applying that wholesale lens everywhere we are. I see integrative medicine as the intersection of biomedicine and non-pharmacological complementary practices. Then if it's kind of like that intersection, why do we keep separating like the settings that we practice? Like outpatient, mostly we are practicing in the outpatient setting, but yeah, when it comes to hospital or inpatient setting, it's kind of difficult to even think about it a little bit. And we know that the practices, integrative practices, they show clinical benefits with minimal side effects, yet challenges to effective integration in the hospital remains. In the past 2 decades, there has been a growing body of evidence showing the benefits of complementary and integrative medicine used in the healthcare system. These therapies are often utilized for common symptoms such as pain and anxiety, and are increasingly being provided to hospitalized patients who may not be fully benefiting from conventional approaches to pain management. So I'm hoping with this presentation, we can kind of change that mindset and continue closing those gaps. And of course, it doesn't matter where you are, as long as you're practicing, just like my dog, he likes to do a lot of meditation, mostly sleeping, but that's okay. That's him. And yeah, talking a little bit about like my personal experience with it, since I began doing my my inpatient rounds, my residents kept asking like, okay, so how can I apply integrative therapies here? And I'm like, I don't really know. Great question. Let's see. So I needed to do a lot of reflection about it. Like, what am I doing? Because sometimes when I go into the hospital, I feel like my brain just disconnects and I need to change my perspective. Like, no, I have to be vigilant or hyper aware of everything that's going on. There are so many things that are moving and that we need to make move. We want to kind of like get them in, stabilize the patient, and just get them out. It's that constant shift. So I was like, let me see how am I practicing this? And I just realized that I started doing kind of like short integrative health consults. Whenever I had like an interaction with a patient and I heard or like they mentioned something that was like, oh, what else can I do to change my or to continue on a better journey for my health? I'm like, hey, there we go. That was my opening. That was my gateway. Like, okay. So whenever I finished doing rounds with my residents, I just went during the afternoon, maybe I took like 15 minutes to go into the patient's room and just talk a little bit like, okay, where do you think you might want to start? Like with your nutrition, or maybe it could be physical activity, so we just sat down. I started doing those little short consults and supporting them with things that they can do when they get discharged. There was another time that I was, it kind of just, it is more innate. I didn't even realize I was doing it. I had a patient, a lot of abdominal cramps, and definitely, they had like the heating pad with the medications. The pain just kept going while we were rounding. And I'm like, is it okay if I massage you? Just doing a little bit of a healing touch at that moment. And that really helped her just try to calm down a little bit and decrease that kind of pain. And in another occasion, just incorporating a little bit of breathing techniques to calm down the anxiety. It's definitely kind of like that story. I think it's funny, but at the moment I'm like, okay, what to do? We were called about this patient that was having atrial fibrillation with RVR and was just spiking up every once in a while. They were having a retroperitoneal bleeding, so yeah, we needed to correct that. But while we were waiting for the specialist to do that, patient, we were evaluating the patient. I'm seeing the vital signs. Okay, blood pressure looks good. You already had your medication. So let's see what else we can do. In some moments when the patient was calm, the heart rate was stable. I was monitoring and between like the 120s maybe. But whenever the patient started kind of like rambling up, worrying about what's going on, they didn't like the setting, they didn't like being in the hospital. That made them a lot of the anxiety rise up. That's where I noticed like just that spike in the heart rate. So I was like, Okay, there's a connection here. I leveled with the patient. I'm like, I have to be honest with you. What I'm seeing here, like, whenever you are kind of calm, yeah, definitely we can continue with that until we resolve, of course, the root cause. But whenever that anxiety is kind of creeping up on you, I'm seeing that your heart rate is also going into the 180s. And I can't have you here because I would need to transfer you to another service just because of that, that acuity of the illness. And the patient was like, and they were mentioning like about the anxiety. I'm like, okay, what have you tried before that has been helpful? They did mention that they prefer breathing techniques. So I'm like, okay, would you like for us to try one? And we just did a little bit of box breathing, calm down the patient a little bit. Heart rate was was going down, like the 120s again. And, it just created that kind of connection between us and also, explaining everything to them as well. It was really like a good experience. So yeah, it's been a fun ride, I think. So how is it looking like now? And mostly this is from my experience at the UW hospital. That's the one that I'm rounding. I began by seeing a couple of order sets whenever patients are admitted. My residents place these order sets, and there was one for nausea with a couple of medications as needed, but also it included peppermint oil. And I'm like, oh, this is nice. Awesome. I didn't even knew they had it at the hospital. And when I did a little bit more research, there is an order for essential oils, including lavender, red mandarin, rose, ginger. Definitely lavender and rose, you can use those like to decrease anxiety, stress as well. The red mandarin, it is kind of like citrusy, so also it's great for anxiety. And the ginger oil, I'm still looking for like how to use it. We do know like with ginger, in the oral form, definitely it does have some good evidence for nausea, but I'm still like, what else can we do with this one? But it's great to know that maybe some hospitals might have a couple of essential oils, so you can use them for aromatherapy. There are supplements as well, and I started seeing them using them as well. It's like melatonin for sleep. We do nutrition consults, definitely keeping in mind food as medicine. There are a couple of non-pharmacological pain management like heat, ice, even the TENS unit. Depending on like the providers that are available or the residents, some of my residents are DO, so they wanted to perform OMT on some patients, osteopathic maneuver therapy. And I'm like, yes, go for it. Or if you know how to do battlefield acupuncture, that might be like another route as well. As for movement, yeah, consults to PTOT, definitely important. And there's also music therapy and pet therapy, but these ones are more in the pediatric ward, and they use it more for patients on palliative care. So next, like what's out there? Kind of evidence that I could look for. There's this really good paper of the UCLA Consult Service. It was done between 2018 to 2020. And they were comparing the readmission rate and length of stay comparison between admissions with a consult with an integrative consult and without that consult in the past 2 years. The services they provided were about the counseling, about modifying risk factors, acupuncture, and trigger point injections, depending on the type of consult or chief complaint. They were mostly consulted for treatment and management of pain syndromes, especially functional abdominal pain, as well as back pain or neck pain. and nausea, vomiting, and anxiety, as you can see from this figure. They encountered that there's a significant decrease in 30-day readmission rates, but in contrast, there's also significant increase in the length of stay compared with control admissions. It went from 5 days usually to 7 days. They did encounter a couple of caveats to this integrative consult. Some like 20% of the consults, they weren't able to perform any of the therapies just because like the patient's condition was improving from prior to having the treatment. Maybe they got the counseling, but not the treatment. There was also like 20% of the patients that were enrolled that declined the treatment. Mostly the common reasons were like continue or worsening of the pain, or they just prefer allopathic medical care in this case. And only 5% of the deferred treatments were due to patients reporting that treatment was ineffective. Next, we have this one that it is addressing pain with the inpatient integrative medicine at a large children's hospital. This one was done in 2017. There were 117 patients enrolled between the ages of 3 to 18. They all received pain consults, but only 18 received the therapies. The services that they included is acupuncture, biofeedback, hypnotherapy, guided imagery, meditation, and music therapy. During this time, they received up to 2 therapies and the counseling. At the time of the consult, most of these patients, they were taking 1 to 5 pain medications. And 53% of the therapies they received was, the preferred one was music therapy, and followed by 24% who preferred acupuncture. An important factor from this study is that there was more than half of the parents that have used any type of integrative therapy in the previous year. So this kind of positively influenced the child's use of the therapies as well. Parents reported that their children had less pain and better mood. Some parents even felt that the therapies helped more for pain than the pharmacological medications. There was only one parent that noted that their child was a little bit more irritable after one treatment with clinical hypnotherapy. But from the 18 patients that received the therapies, they all reported decrease in their pain. There's also an integrative medicine consult inpatient as well from the Marcus Institute of Integrative Health at Jefferson Health. It started in collaboration with the oncology department. They are doing their consult clinics, and they're mostly modifying all the chronic risk factors, and they include like dietary guidance and education to utilize when discharged, healthy physical activity options and recommendations, stress reduction strategies, managing of symptoms like anxiety, insomnia, pain, fatigue, or nausea. They also included a little bit of supplement reviews if the patients are taking them or not. And they were also consulted if the patient had any particular interest into any integrative approach. Next would be the use of battlefield acupuncture or auricular acupuncture in the emergency department. With this is a meta-analysis I found of 6 RCTs and 2 observational studies. They were mostly trying to think of new therapies that whenever you're trying to introduce something to that setting, mostly in the emergency department, They have to be some characteristics that should be ideally required for any new analgesic modality, like efficacy, rapidity of administration, low side effects, minimal post-administration monitoring, improved patient satisfaction, and low cost. That's why having battlefield acupuncture is really like one of the interests in this. They compare a lot of all of these RCTs. They were comparing like battlefield acupuncture versus sham acupuncture, comparing it as an adjunct to standard of care, or just as a sole therapy or adjunct versus a controlled setting. The most important conclusion of this review is that ear acupuncture has some limited evidence of effectiveness for acute pain in the emergency setting as a standalone treatment and as an adjunct treatment. Still, these reviews provided evidence that all forms of acupuncture were effective in the ED environment, and they are really effective when it comes to acute, to reduce medication usage in the perioperative pain, but not in ED. But yeah, as an adjunct or to standard analgesic care, or as an alternative when concerns about analgesic drug side effects are high, they are contraindicated or previously ineffective, it did show that there was a significant reducing in pain. After that, there has been a couple of other studies in the past few years. This one from 2021 is addressing battlefield acupuncture in the emergency department, but comparing it versus standard pharmacologic treatment for low back pain. They are targeting more like the specific conditions. In this one, the primary outcome was having a mean pain reduction, and at 30 minutes or 30 or 40 minutes after administration of the therapy. And the secondary outcome would be having reevaluating them at 48 to 72 hours. And they did see that there was a great reduction in pain when the battlefield acupuncture group at 30 to 40 minutes. And in the 48 to 72 hours, the use of prescribed or over-the-counter rescue medications for further analgesia was 83% in the battlefield acupuncture versus the control group. Speaking about like auricular acupuncture, I just wanted to introduce this protocol because I think it does have a good interest when it comes to the inpatient setting. It is called the NADA protocol. It is a standardized 3 to 5 point ear acupuncture protocol. And it has been used not only for patients with substance abuse, but also for broad behavioral health applications, stress reduction technique, and improving sleep and coping, not only for patients with those with substance abuse problems, but also in those exposed to horrific trauma. And talking about like the NADA protocol, it has been used, this study mentions its use in a Denmark palliative care ward. And in this one, the patients and also the family members, the caregivers, they both receive the auricular acupuncture. And with this, it was a qualitative study, taking in their perspective on the protocol. They had a total of 10 patients and 15 family caregivers in their interviews, and it resulted in a relief of the suffering, which both patients and family caregivers noted positively influenced the rest of the day. It provided feelings of inner strength and the ability to look more positively on life, which enable awareness of their surroundings and thus feeling more alive. It also made possible for family caregivers to share in the experience of the treatment, generating the feelings of being involved and respected. Several patients and family caregivers described sharing the experience as beneficial because it promoted a focus on the family as a unit. So yeah, I think it really provides like this really good integration of what we practice every single day. Talking a little bit more about other therapies like osteopathic maneuver therapy in the inpatient setting. There is this study about the effect of osteopathic maneuver therapy, comparing the length of stay in elderly with pneumonia. This 2022 meta-analysis favored the use of the therapies to decrease the length of stay. It did show a good improvement of that. And they took into consideration this other analysis about in 2016, also comparing like osteopathic therapies in pneumonia for in the elderly. And this one here, they kind of like their outcomes were checking the hospital length of stay, if the patients needed or not ventilator dependent respiratory failure, and comparing as well in hospital mortality rate. They usually what they were doing is some DOs try to figure out like a good protocol to do in this kind of patients. They were into the techniques that they integrated at this moment was doing a little bit of thoracolumbar soft tissue, rib raising, doming of the diaphragm with myofascial release. They also did a little bit of cervical spine soft tissue, suboccipital decompression, thoracic inlet myofascial release, and thoracic lymphatic pump and pedal pump. With this, it did show that in patients with pneumonia, it reduced their length of stay, as well as doing, of course, the traditional standard of care, and between the ages of 50 to 74 years, and it did lower in hospital mortality rates in adults aged 75 years old or older. And there's also this study in 2022. It was a retrospective study in patients with COVID and using as well the osteopathic therapies. This was mostly like doing their experience with the therapies. During the study of period, all of the patients, they also received standard of care for COVID as per the guidelines. When the survey was staffed by an attending physician trained to perform OMT for respiratory distress, all patients seen by that clinician were eligible for OMT. They were offering it to the patients, and they were offering at the encounter if they accepted, and also daily for as long as that patient was on or the provider was on the service. There were 179 patients in the study, 27 received OMT, and 152 were control that were treated on that service. From this process, they were applying just 4 therapies of osteopathic maneuver, like rib raising, abdominal diaphragm doming, thoracic pump, and pedal pump. They did see that there was a lot of acceptance of the therapy and satisfaction from the patients. There were less side effects from this, and the patients did felt that there were more, like they could breathe easily after the therapies. So when it comes to doing integrative medicine in the hospital setting, as everything, there's going to be challenges. From all the studies that I was reading, there has to be dedication and interest from the hospital. That's the way they're gonna support you. There's also the need for funding, just to support the staff, support all of the providers. And especially, there has to be discrete dedicated time to offer the services. Most of these providers were doing the therapies in their in their own time, like they did it before going to clinic early in the morning or just late in the afternoon after their clinics. So yeah, that's kind of like a big thing to consider whenever we try to do this. And well, for myself, if I did have like the 15 minutes in my afternoon, I was like, okay, let's just try this. And of course, there's further studies that are needed to investigate the integration, the cost, and the cost effectiveness of integrated therapies. But, but as we all know, and as Leon Wan stated in his study, complementary and alternative medical treatment differs from conventional medicine in that therapy is often tailored to the individual patient. This personalized holistic approach is fundamentally at odds with the constraints of the RCTs. So keeping that in mind. Let's see. So is there, just reflecting a little bit, is there anything else that we can try that it doesn't have to do maybe extra time or extra fundings for this? And yes, there are things that we can just integrate in our practices. First of all, we have to go back to the basics, keeping in mind the healing encounter. That is our most powerful tool ever. We do know that there's going to be, in the hospital setting, there's going to be a lot of pathologies, but we also need to change our mindset and trying to go to the salutogenesis and the creation of health. With this, we're going to facilitate health and well-being that transcends the physical alone and results in less suffering, greater understanding for the patient, and improved quality of life. And for that, simple things that we can do just because it's a good reminder. So just going to those 3 P's: pause, present, and proceed. With pausing before crossing the threshold of the room to clear your own clutter. In the hospital setting, it is very fast-paced. We are thinking of everything else besides the patient. And yeah, that happens to me. That happens to my residents, everyone. We're humans, we know that. But just going to that and giving that reminder to ourselves, it will be beneficial. We have to be fully present and mindfully aware, creating insight into the individual's authentic needs. And then we proceed toward the action that you both agree and will bring focus to a healing path. In pausing, being present, and listening to the patient, insight arises, allowing to create a plan. And also practice compassion, realizing that in serving others, you will serve yourself. We can also, going back to like keeping in mind our whole health approach, how can we optimize the current treatments? Are there any electrolytes that we need to supplement? Are there vitamin deficiencies? If they are on supplements, we can do interactions with the natural medicine database. How is their sleep? We know sleep isn't great, so how can we improve that? And as well as nutrition. And sometimes, do you think they benefit from a spiritual consult? Consider the chaplain; those services are always there. And keep it in mind, like we can do some nurse communications, just making sure maybe we don't need the patient's vital signs at 1 o'clock in the morning. So, placing that nurse communication so you're allowing them to sleep and rest, or if the patient is able to walk and it's safe, just let them out. If there's like a garter or something, just place that nurse communication that they're able to do it, because being confined in those 4 walls, it's really not fun. So little things. I do wanna point out that there's something that is really, I don't think we think about it too much, but it's really helpful in so many stuff and that we can also incorporate in the inpatient setting. It's helpful with asthma, COPD, constipation, insomnia, for arrhythmias, migraines, for patients with chronic pain and malnourished. And we need to keep that in mind because it's gonna be deficient in every patient that has prolonged use of PPIs and metformin. And of course, that is my really good friend magnesium. I love it. That's one of my biases, but it's really helpful. With magnesium, we do know that it is used like in 300 different metabolic things that are happening in our body. So if we keep that in mind that some patients might need that extra help, you can also start them on that one. The recommended dosage is going to be 250 to 800 milligrams. My residents always ask me, oh, but there's so many presentations. I'm like, that's correct, but at least get to know two of them and that's going to be all right. In this case, magnesium citrate and glycinate, they may be better absorbed and they are known to cause less GI upset compared with the oxide or the hydroxide. Keep in mind, use caution with renal function. And in the hospital, we do have the magnesium oxide and the citrate solution. And of course, the IV sulfate, which we know is really helpful as well. Yeah, I place a little bit about like the dosing in there for children. Really, it's not necessary to supplement unless they have like the deficiency and you need to supplement with the IV sulfate. But always keep in mind that you can introduce magnesium in your foods with legumes, nuts, seeds, whole grains, and green leafy vegetables. So food as medicine, always keep that in mind. If they are going to be used and the patients are antibiotics, the antibiotic might not be absorbed if taken too soon before or after taking the magnesium. So keep that in mind. The use of diuretics can either increase or decrease the loss of magnesium through urine, depending on the type of diuretic. And yeah, and if you have your patient on long PPIs or metformin, also keep in mind they might need a little bit of a boosters in there. There's also omega-3s that we can also start them in the hospital. They have good research supporting management of heart disease, triglycerides, high blood pressure. Also, there's fair amount of evidence when it comes to chronic pain, but treating osteoarthritis or rheumatoid arthritis, especially managing the symptoms, it might be good. If you're using it for heart disease, 1,000 milligrams would be daily, would be beneficial. Or for chronic pain, it's just a little bit higher, 2,000 milligrams. Probiotics, definitely keeping that in mind. I don't think we use them a lot, like it just goes by our minds. And we do have on formulary only lactobacillus rhamnosus. It does have good evidence for IBS, but it has to be used twice daily. For viral gastroenteritis, twice daily as well for 7 days or the duration of the symptoms. And if we want to help prevent diarrhea caused by C. diff, a lot of patients on antibiotics, we have to keep in mind that the ones that have good evidence for this is Lactobacillus acidophilus and casei. But if you don't have it, it's okay. At least start them in something and you will help with that leaky gut. Ah, my favorite. The integrative handouts. You don't know how many times I'm like, yes. If we don't have a lot of time to talk to the patients, just I keep printing them out and just highlighting the parts that I want the patient to pay more attention to this. And there's are some good resources there for leaky gut, the anti-inflammatory diet, for heart failure, DASH diet, for anxiety, insomnia, and also good resources for mindfulness or other practices as well. And yes, one of my favorites we did with thanks to Oh my God, it's the Collective for Humanism, Arts, and Storytelling in Medicine department. We learn more about narrative medicine. It is the art of telling the stories and the art of deeply listening to those stories, which are used to be central to the relationship between the patients and the clinicians. It does mention that those arts are often undervalued in medical encounters that tend to privilege the biology over the biography. And this creates a disconnection between the patients and caregivers that can be repaired by promoting the role of telling and receiving the stories as central in clinical exchange. We learn about doing a vivid vignette. It is a one-sentence description of a patient that encapsulates aspirations and obstacles to achieving those aspirations. You do need to let the patient know that you're using the vivid vignette. It reassures the patient that you see them as a person. And yeah, just seeing the patient, using this, you're gonna see the patient more vividly as a person. It will enhance the interactions with the patient, and it's more like a part of an evolving story. A good example here is like our typical HPI, we have their age, we have their gender, and then it's this whole history of all their conditions. But we don't know who is the patient. So we do ask a lot on our PHI, like what do you live for, what matters to you, why do you want to be healthy, and what brings you joy. And if we change that narrative, it will look a little bit more like a 65-year-old artist who continues to have that pain in their shoulder. Oh, sorry about that. And it's affecting their quality of life. So you get to know your patient. He is an artist, and this current chief complaint is what's keeping him from doing his art. So just trying to get that one-liner in there, that's really like an awesome outlook. Let's see what else. I recently learned also about self-acupressure. It is being used for patients with sickle cell. And yeah, like there are providers teaching their patients to use these resources. It is the simulation of acupuncture points with pressure from fingers or a device. It is low cost, minimal instructions, patient controls the dosing and timing, and empowers the patient. There's this really good app, Acu app, that's gonna tell you like for how long you should do it, if it's like a tap or just pressure in the area, and which point is it with an image. So it is one of those good resources that we have. There's a lot of opportunities for expansion or collaboration with other departments, especially the palliative department. They see a lot of chronic patients, and they're really great at getting that narrative medicine down. Like they get to know the patient. So if you don't have a lot of time, and the patient deserves like a consult for palliative care, that could be like one route, like good resource to have on your team. As for pain department, we are doing a couple of seminars with them, letting them know about other therapies for pain management. And the addiction department, I think that would be like a great connection if we start doing the NADA protocol, because I do think that our patients might benefit from it. When it comes to training, if you want to know a little bit more about battlefield acupuncture, last year, we did one seminar in the Family Medicine Midwest Conference, really good, just for training students, training residents, as well as physicians. There was also one time last year as well, the Faculty Development Day, where there was another seminar about this. And there's also the VA training. As for OMT, we do offer the OMT for MD, which is a longitudinal course for allopathic physicians on these therapies. I'm doing that one right now, and it's really great and eye-opening. Just another resource. And what can we do for our own well-being? Definitely educating the staff on wholesale. That's That's like the best way, getting everyone around you into that whole mindset. Doing regular check-ins with your team. We did one thing when and it was with our residents. Just saying one positive things about their management or their personality for the person next to you, and that was really empowering. Encouraging a lot of physical activity in the meantime, like just taking the stairs, that's also helpful. Get your 10 minutes of sunlight. You need to get out or at least see what's outside. And there are a couple of quick therapies like to decrease anxiety. It's really difficult to do kind of meditation practices, but you can do some deep breathing or somatic exercises like the butterfly hug that are quick kind of fixes to decrease the anxiety. And my favorite at the hospital, my garden getaways. I just took my laptop outside when it was beautiful, and that was my office. Even if it was for like 30 minutes, it was great. So I do encourage my residents to do that a little bit for at least a couple of minutes. And even one time I did a couple of feedbacks with them in that setting, and I think they just felt more relief. It wasn't that strict when we just go to a closed room. And if not, if you can go outside, just at least look at it. If you have any type of gardens or things like that, it's really beneficial for both providers as well as your patients. And lastly, oh my God, we are our worst own critics. That's something I experience a lot. My residents do as well. So, what do we need for this? Loving kindness, definitely. The challenge with empathy is that when you feel someone suffering day in and day out, it can lead to negative feelings, withdrawal, non-social behavior, and even burnout. So just practicing the loving kindness, this has been a game changer for me. I've been practicing, I think, like for 3 years now. And I started with listening to Sharon Salzberg's podcast. So yeah, I think we did a little bit of that practice earlier today. So remember to start with yourself, following these affirmations, then tend to your loved ones, then to a neutral person, and then someone who is challenging or difficult for you, and then to everyone. And yeah, I think that's it for today. I thank you all for listening. I hope it was really beneficial or something. And if you do see ghosts while you're in the hospital, be aware. Or yeah, even if they are cute like this, that's okay.